single tonal frequencies. And if you've got central auditory processing disorder, it doesn't impact your ability to hear tones. It's a simple sound. Central auditory processing disorder affects more complex sounds, as speech, especially in the presence of background noise. When I'm talking at the moment, my voice contains many different frequencies. I've got the vowel frequencies, which is the lower frequencies, and also the higher frequencies, the consonant, the beginnings and endings of words. And central auditory processing disorder is when your brain receives these different frequencies of sounds contained within speech and background noise in the incorrect order. So it's another term given for it is auditory desynchrony, auditory neuropathy. These things all affect the transmission of sounds to the brain or the brain's ability to process it. So the best way to describe central auditory processing disorder is if you go to an orchestra and you've got all the different types of instruments being played and you don't have a conductor, and so all these different instruments are being played but not in synchrony. They're played out of synchrony. So the brain can receive all the sounds, it's hearing all the instruments, but not in the correct order. But once you've got the conductor there controlling when each instrument should be played and what order and what synchrony, that's when things sound more clearer. And if your brain loses the ability to do that, either because it's not processing it properly higher up in the brainstem or in the auditory cortex, or the auditory nerve in some ways not sending those signals through. You can get someone with absolutely normal hearing thresholds, and we do a hearing test, it comes back normal, but we then do a speech and noise test and other tests to decipher whether they've got a central auditory processing disorder. So hopefully that gives you some information and background about the different types of hearing loss and the causes for it. So patient 2, we've cleared their left ear, as you saw. It's similar to patient 1, very dry earwax and dead skin. Similarly, a bit of a narrow ear canal, but not as narrow as patient 1. I had to use forceps just there just to extract a very dry form of wax. You can see this attaches to the canal wall. You've got skin adhesions here. And I just want to remove as much as possible for the patient. They do wear hearing aids, and they've got their hearing aids where they have domes. So this dome is attached to the end of the hearing aid, the speaker, also known as a receiver. When it's pushed into the ear, it can slightly graze the side of the ear canal wall and push this dead skin off the canal wall. And that dead skin can also block the centre of the dome, and that's where the sound bore is, that's where the sound comes through. So it can cause a reduction in sound for the patient, and sometimes acoustic feedback. When sounds are amplified into the ear by a hearing aid, inevitably some of the sound will escape back out of the ear. And the sound that's already been amplified can re-enter the hearing aid microphone for it to be processed and amplified again. And that cycle continues. So a sound that's already been processed and amplified into the ear escapes, re-enters the microphone, and the hearing aid inadvertently processes it again. So that sound keeps getting processed over and over again. We call that a feedback loop, and it causes the hearing aid to squeal or whistle. So I just want to remove as much debris for the patient to ensure they're getting the maximum level, optimal level of amplification, and minimise the risk of any feedback, because it's one of the things that they do sometimes experience. But of course, we're not going to be able to get every little aspect. We're just trying to peel away as much as we can. Because it's on the cartilaginous portion, the outer